Hi everyone, my name is Jillian Goles. I'm an interdisciplinary studies major with a concentration in pediatric health. I'm here to talk to you today about seclusion and restraint policies and practices in the psychiatric setting. I'd also like to start off by thanking all of my faculty advisors, Mr. McAlpin from the Interdisciplinary Studies Department, Dr. Fleischman from the Biological Sciences Department, and Dr. Stewart from the Health Administration and Public Policy Department. I'd also like to start off by sharing a personal story, something that I witnessed while I was employed on a psychiatric unit previously. All identifying demographics have been omitted to protect the patient. John was a 16-year-old patient who was with us at the time. He had had numerous seclusions that day and also restraints, 3 within a 1-hour period to be exact. This patient was giving staff much difficulty in his treatment, very combative, as you can imagine, much larger than most of our female staff. Approaching one of his seclusion events and another one of his combative episodes, a staff member approached him in a very comforting manner, or what she thought was a comforting manner, to try and avoid yet again another seclusion and restraint for this patient. Unfortunately, the patient was again combative and punched the staff member in the nose, and she is now forced to get reconstructive surgery due to this event. I'm sharing this story with you because this is a trade-off that we are now examining in the psychiatric field of whether or not seclusion and restraint should be utilized to protect the patient, to protect the staff, etc. So what are seclusion and restraints? This is something as my audience you guys should be able to understand in order to progress through this presentation with me. A seclusion is the placement of a patient in a room, usually locked by staff or where the entryway is blocked, so the patient cannot get out. The definition of a restraint is the use of physical force, a mechanic device, or chemicals, usually PRN medications, which are not part of the patient's normal medication regimen, to immobilize the child or the adult and prevent them from leaving the room. This is an example of what we call a sensory room or a comfort room, which is also a form of seclusion rooms. A sensory room has a beanbag chair, a ball, sensory items that the child can sort of comfort themselves with, cope with, etc. And then the difference between this and a seclusion room would be that a seclusion room has bare walls, bare floor, absolutely nothing in it, so the child would be unable to harm themselves at all. This is an example of a mechanical restraint. This is a 4-point restraint where you can see that all of the patient's limbs are strapped to the bed. Usually these are strapped via leather or padded belts. And then the third, again to remind you, the third type of restraint is the chemical restraint, so some type of medication that is not part of the patient's normal regimen. This leads me to my capstone question. What are the current conflicting perspectives regarding the methods of seclusion and restraint in the psychiatric setting? So why should we research this topic? In 1972, there was a precedent case, Wyatt v. Stickney, that basically set the minimum standards for patient care for those patients with mental health diagnoses. However, today there are no uniform policies for seclusion and restraints. This means that all institutions can put forth their own policies regarding these methods. The purpose and goals of my research were to, again, weigh the risks and benefits of seclusion and restraint, to determine the risks to both staff and to patients, to research whether or not seclusion and restraint is somewhat inhumane or whether or not it should still be used to protect staff and the patient. And then finally, I'd like to suggest other less restrictive alternatives. In order to research this topic adequately, I use relevant disciplines and fields such as psychology, which many concepts stemming from aggression to operant conditioning to anxiety to stress All of these I used to research this topic. The next field that I utilized was medicine. I used concepts such as anatomy, physiology, treatment, interventions, all of these common in the practicing of medicine. I then used health policy. Health policy would utilize concepts such as decision-making, compromise, equity of care, delivery of health care, and the quality of health care. And then finally, I utilized history as a secondary discipline to support the background of my topic and to track the evolution of seclusion and restraint methods in the field. Methodologies. I utilized a literature review, approximately 15 articles coming from Johns Hopkins Medical Welch Library. I also used a policy review of seclusion and restraint policies from Johns Hopkins Hospital, Franklin Square Hospital, and University of Maryland Medical Center. Additionally, I utilized case studies, most of these found in literature, not from my unit specifically. So many of these many of the articles interviewed patients regarding the positive and negative aspects about their experiences with seclusion and restraint. And then finally, I did 3 professional interviews with registered nurses on a Johns Hopkins psychiatric unit. I used a 10-question survey which asked the nurses about their opinions regarding seclusion and restraint and if they felt it still necessary. Integrative strategies. This is where the interdisciplinary portion of my project really got great. I utilized the strategy of advancing through checks and balances with psychology, medicine, and health policy. This strategy helped me to form a more holistic and balanced approach. So aspects from psychology, medicine, health policy, they're all involved in a sort of reciprocity with each other. They are checking to make sure, for example, is medicine really utilizing the aspects of mental health that it should be? Are we taking enough consideration to the mental health of our patients? The next strategy that I utilized was bridging the explanation-action gap. I utilized the disciplines of history, psychology, and the field of health policy. This strategy in particular helped me to track the evolution of policies and practices, thus leading to future interventions. So this really helped me make recommendations at the end of my project because I already had knowledge of what had been tried, what worked, what didn't work, etc. Finally, I utilized the strategy of building complex and multi-causal explanations with the discipline of psychology, the field of medicine, and again, the discipline of history. So this helped me to kind of answer the question, why should seclusion and restraint be continued or discontinued? So again, each discipline offering its own explanations of whether or not it actually felt that seclusion and restraint was still necessary. Common ground. The common ground technique that I utilized was called extension. In utilizing extension, I extended the definition of interventions from psychology into medicine, and I also redefined it quite a bit. Interventions should really be utilized before a patient escalates, not just after a patient escalates. So normally when we think about interventions, we think about, a patient already acting out, already being combative to staff, and now we're trying to solve the problem. However, I think it's important for interventions to be utilized when staff really starts to see those warning signs. So before those seclusion and restraint events actually happen. Weighing the risks and benefits. For example, some of the risks involve physical injury, PTSD symptoms, of which I found an article that exactly underlined both the PTSD symptoms of both staff and patients involved in these events. Exacerbation of mental illness, so if a child already has anxiety, a seclusion or restraint event in which they are placed in a room by themselves and where it is enclosed, could also exacerbate their illness further. Those are just some examples, but if you continue to read the list. And then benefits. So seclusion and restraint enables staff, and I especially witnessed this on my unit, enables staff to better administer treatment. So sometimes a child would wake up in the morning and say, you know what, I really don't feel like taking my medication today. But This isn't okay. This is part of us being able to treat them. So at times, seclusion and restraint helped us to administer those medications to the child when he or she was being combative towards staff. Most importantly, I think that seclusion and restraint was designed to limit self-injurious behavior. So it was designed with the patient in mind, to keep them from, cutting themselves with things or trying to find things in their room that they could possibly injure themselves or staff with, or possibly another patient. Findings. So before I go over my conclusions with all of you, I would just like to summarize basically where I got my information from and how it was specifically important to the conclusions that I drew for my project. So in my literature review, I found a specific article that mentioned that behavioral systems for patients were extremely important. This because they help to intervene prior to seclusion and restraint events. So if a patient is constantly being rewarded for their positive behavior, they're less likely to actually have a seclusion event. Additionally, there has been proven effectiveness to debriefing for staff and patients after these events. So this means the staff on a psychiatric unit, after a patient was secluded or restrained and the situation has been harnessed, the staff would get together, possibly in a boardroom, and talk about how it could have been avoided, how the situation could have been improved. So basically they're making implementations for the future, making suggestions for the future, so that if anything happened that was derogatory, it can be changed. Additionally, I utilized a policy review. There were many differences in the policies that I reviewed. Again, this stresses the importance for a uniform policy, whether it be state, whether it be federal, it's extremely important. Additionally, case studies. So I mentioned before that I had found specific case studies in my literature review. So these mentioned patients' positive and negative experiences with seclusion and restraint. Many of the patients said that their positive experiences came from when staff did debrief with them, told them why the seclusion or restraint event was necessary, and then also they found better results when staff were particularly compassionate to the patients. Finally, interviews. The nurses preferred alternative methods, so they really did not want to seclude or restrain a child. They really had the patient's best interest in mind. However, they do like the fact that seclusion and restraint is available as an option to them because it gives them sort of a last resort and guarantees them safety. Conclusions.
Sorry, I totally was writing something down. Yeah, 30 seconds if you can wrap it up, that's great. Thank you.
Conclusions. So my recommendations for the field involve a uniform law, again, in the U.S., whether it be state mandated or federal. Again, it is extremely important to make sure that all institutions are held accountable for seclusion and restraint events. Importance of competency. So for example, as of right now, the unit that I had previously worked on only had compliance reviews for crisis intervention techniques, which is, again, something that's involved in seclusion and restraint, about every 6 months. I think that these should be implemented every 3 months to make sure that the staff on these units are competent so that we can reduce the amount of injuries and risks involved with these methods. And finally, I would also like to suggest a behavior chain. I talked about the debriefing, and also a behavior chain analysis with the patients. So this is actually a worksheet that you can find online that goes over how behavior is escalated. So the more that the patient can understand their behavior, the more that they can kind of reduce the likelihood that any of these events will happen in the future. And finally, I'd also like to suggest an art cart. This is something that exists on the unit that I previously worked on. This was not found in my literature. This was solely something that I feel will be great for patients to have. Art for many psychiatric patients is a coping skill. So if we're providing our patients with coping skills and ways that they can cope on these units, again, we're reducing the likelihood that seclusion and restraint will actually occur.
Thank you. Question?
Yes.
Yes, Jillian, you had 5 suggestions for the future of SR.
Mm-hmm.
Of those, which you mentioned at least the last, the art card, is unique to you,
Mm-hmm.
and which are already being implemented in test locations around the country?
So I think that staff debriefing, again, I think they're all being implemented at the moment except for one that I could not find any research on whatsoever, which was connecting seclusion and restraint specifically with particular disorders. So this would look at being able to address whether or not a patient, being an individual, would actually benefit from a seclusion or a restraint. So again, on psychiatric units, we have patients who have a history of aggression, depression, anxiety. Any of these patients have the capability to act out and be combative to staff, but I think that there should be more research on whether or not specific patients with certain disorders would actually benefit from these methods. Does that answer your question?
Yes.
Yes. Okay.
Well, let's prioritize our students.
Oh,
And
okay.
everything will-
You had mentioned that there currently aren't any really all-encompassing laws or policies regarding restraints, but what about accrediting bodies like the Joint Commission? Do they have anything to say about this, and why not follow their recommendations?
So the Joint Commission actually works off of that main precedent case, which was in the U.S. Federal District Court. And that case, like I said, basically underlined the minimum requirements. So when the Joint Commission, actually, they visited my unit prior. And when I was there, basically all they wanted to make sure was that our seclusion rooms were safe and fit for patients to be in. That any type, my unit specifically did not use any type of mechanical restraints. So all of our staff were checked to make sure that they were certified to physically restrain a patient. And then chemical restraints, obviously being medications. I'm not a nurse, so I'm not exactly sure what was involved with that specific regulation. But the Joint Commission, again, I believe works off of that precedent case, and there are no uniform laws at the time. So they're just making sure that our policy is consistent to that one case, which again is why I'm so concerned.
Okay, so it's not the Joint Commission saying this is what you should do. It's just saying,
It's
okay,
just
what you're doing is okay.
Make basically a check marks the box.
Okay.
Mhm. Yes.
You said that nurses should, or that professionals on these wards should think about interventions proactively, and they don't do that. I mean, I was thinking, it would seem like that they would, if you're looking at who's on your ward, this person, maybe there's an issue, let's think about what the day might be like, what are the situations. So I was wondering about that proactive.
You would think that that would be part of a care plan. As a nurse, you're prepping for the day and you're reviewing your patients, and you want to know what kind of coping skills they like. However, I think that so many units have so many patients that when the nurses come in, they're so often overloaded with, okay, I need to give this patient their medication, I need to give that patient their medication, that oftentimes the little things, what I think a lot of people perceive as little things like coping skills, like, oh, well, he or she likes to draw. Those things are seemingly forgotten. So I think that each day, part of kind of going in and getting information on all of your patients, part of that should be, okay, well, what are his or her effective coping skills? So I think that staff do participate in that on many units. However, I would like to see more of it, and I think that sometimes it takes an event for a horrific event, some seclusion event for a child, for staff to actually pay more attention to that and then develop coping skills particular or specific to that child.